Welcome to The Explainer. Today we're going to talk about the anatomy of a major medical decision, fusion versus disc replacement.
If you have been told you need spine fusion, and a friend, a podcast, or a Google search has put the words disc replacement in your head, this video is for you. The honest answer is more interesting than either side of the debate. You know, it's a crossroads thousands of folks find themselves at every single year. You're sitting at your kitchen table after a surgical consult, laptop open, just wondering what your true options actually are. Well, today, we're going to break down the anatomy of this decision using the absolute most current medical data available.
Here is our roadmap for today. 1. 2 surgeries, 2 different goals. 2. The rules of eligibility. 3. Neck versus lower back. 4. Why motion preservation matters. 5. The surgeon and the future. And finally, 6. The Vertrae approach.
All right, let's dive right into section 1. 2 surgeries, 2 different goals, fundamentally different.
This right here brilliantly illustrates the core difference between the two. Fusion and disc replacement are 2 totally different operations, and they have 2 entirely different goals. Fusion stops motion at a single, painful level of the spine. Basically, the surgeon takes out a damaged disc, pops in a spacer, and lets the bones grow together into this nice, stable foundation. Disc replacement, on the flip side, preserves motion. An artificial device, usually made of metal and plastic, replaces that damaged disc, allowing that specific spinal level to keep on moving. And the absolutely crucial takeaway here, neither one is automatically better than the other. Both have very specific, very important clinical roles depending entirely on what's actually wrong with your spine.
Now, it's also absolutely vital to understand that fusion is a broad category. It is not just one single procedure. You know that traditional open back version with the brutal recovery that most patients immediately picture? Yeah, that's not the only option anymore. Take MIST lift, for example. That stands for minimally invasive transformational lumbar interbody fusion. It's a mouthful, I know. But this is the exact approach Dr. Kamal performs over at Vertrae. Instead of a massive cut through the muscle, the surgeon works through these tiny incisions, just gently pushing the muscle aside. What does that mean for you? Well, significantly less blood loss, lower infection rates, and honestly, just a completely different patient experience. So when you hear those horror stories about long, grueling fusion recoveries, you're usually hearing about the older, open approach.
Okay, moving right along this section 2, the rules of eligibility. Who actually qualifies?
Let's look at a landmark 2004 study out of the Hospital for Special Surgery in New York. They looked at 100 lumbar surgical patients just to see who was actually a candidate for a lumbar disc replacement. And the result? Only about 5% qualified. Yeah, just 5%. The other 95% had at least one clear medical reason, a contraindication, why the surgery just wouldn't work for them. So listen, if a doctor tells you that you aren't a candidate for lumbar disc replacement, you need to know that this is just standard anatomy at work.
So what exactly are these anatomical disqualifiers? Well, remember, an artificial disc replaces the damaged disc, but it literally cannot fix the structural problems around it. If a patient has bone instability, like say a slipping vertebra, or severe arthritis in the small facet joints behind the disc, a replacement just won't help. Things like spinal deformity, weak bones from osteoporosis, or problems at multiple adjacent levels, all of those make a patient a pretty poor candidate. In those specific cases, fusion is overwhelmingly the better and safer operation.
All right, section 3, neck versus lower back. 2 totally different stories. This is a big one. Most patients who hear these amazing, life-changing success stories about disc replacement are actually hearing the cervical or neck story. Cervical disc replacement has been around for over 20 years. It's widely available, and it has a much broader candidacy. But lumbar disc replacement, down in the lower back, that is a completely different ballgame. Lumbar candidacy is so much stricter. Because your lower back carries way more weight and sits right behind major blood vessels, the surgery usually requires going in through the front of the abdomen. That often means bringing in a vascular surgeon just to move those major arteries safely aside. You simply cannot compare the neck and the lower back as if they're the exact same procedure.
Which brings us to section 4, motion preservation, why it matters.
Check out this number, 1,474. That comes from a 2016 meta-analysis published in the European Spine Journal that looked at almost 1,500 patients. The researchers found that folks who had motion-preserving surgeries actually had lower rates of something called adjacent segment disease. Basically, when you fuse one level of the spine, the levels right above and right below it have to work overtime to compensate for that lost motion. And over the years, all that extra wear and tear can cause those neighboring levels to break down. That is the real, hard, data-driven rationale for motion preservation. It's absolutely worth asking your doctor about, assuming it fits your specific anatomy.
Next up, Section 5, The surgeon and the future. Evolving perspectives.
Now, what's really interesting here is how two incredibly thoughtful surgeons can look at the exact same patient and recommend different things purely based on their training and the tools they have in their toolkit. Look at this 2022 study. It followed specialized surgeons whose entire practices are built around disc replacement. And guess what? Even among their highly pre-selected patients, these specialists still recommended fusion 35% of the time for lumbar disc degeneration. That proves that even for the absolute biggest advocates of disc replacement, clinical judgment dictates that fusion is frequently the right answer for the spine right in front of them. Neither side of the recommendation is automatically wrong. And we also have to recognize that what's true today in 2026 might not be true in 2030. This technology is evolving incredibly fast. We're moving from today's front abdomen and lumbar approaches and traditional fusions toward emerging posterior facet-preserving technologies that are actually in clinical trials right now. Fusion and disc replacement will likely continue to serve different, overlapping roles. One isn't just going to completely replace the other anytime soon. The picture is going to keep changing, which is exactly why staying informed is so absolutely critical.
Finally, let's wrap up with Section 6, the Vertrae approach, putting the patient first.
Let's look at how this plays out in the real world. At Vertrae, located in Miamisburg, Ohio, Dr. Kamal Woods is a dual fellowship-trained neurosurgeon and spine surgeon with advanced training from Cedars-Sinai. Because Vertrae is a comprehensive spine-only practice, they have both fusion and motion preservation tools readily available in their arsenal. What that means for you is that the final recommendation you get depends entirely on your unique anatomy and symptoms. It doesn't depend on what the practice just happens to prefer doing. If cervical disc replacement is the right fit, they do it. If minimally invasive fusion is the right fit, they do that.
I think this quote from a Vertrae patient really hits the nail on the head. He presented me with a range of treatment options and didn't push me towards surgery. When a surgeon truly prioritizes clarity, they present options based on your specific spine. They explain exactly why you are or aren't a candidate for a certain procedure. Remember, you are absolutely allowed to ask your surgeon why fusion is being recommended, and you are 100% allowed to seek a second opinion to make sure every single option is on the table.
Ultimately, that leads us to this final thought. When you're sitting there looking at your scans and talking to your doctor, ask yourself this. Is your goal just to get a specific procedure you read about online, or is your goal to get your life back? The procedure is just a tool. Your life, that's the goal. Use this information to take charge of your next consultation with clarity and confidence. Thanks for joining us for this explainer, and remember, keep asking the right questions.